Hi, good afternoon, and thank you for joining us in our annual SG EndoMarch Awareness Talk. My name is Namira, and I am the founder of E for Endometriosis. Today, I am wearing many hats: that of the event organizer, the host, the technical support, and the list goes on. A short introduction of myself. I am a one-woman army. So besides advocating on endometriosis, I also juggle a full-time job, wife duties, and caring for my parents, being their primary caregivers. I also suffer from multiple chronic conditions, with stage 4 being one of the many. More about me and my journey living with endometriosis on Instagram, E for Endometriosis, and website endosupport.sg. E for Endometriosis is turning 10 this year, so expect more giveaways. And I will also post on all my social media accounts, Instagram, the Facebook Singapore Endometriosis Support Group, and the website by tomorrow on ways you can reach out to our speakers, Dr. Mali and Dr. Annabelle. So follow, subscribe, like, and share to not miss out on valuable tips and information in managing your symptoms. Disclaimer: do note that online conferences cannot fully replace face-to-face consultations due to various limitations. It is to be taken from a general point of view, so please follow up with thorough examinations from the healthcare professionals. Do note that this session is recorded and will be used for our endometriosis awareness campaigns. To make this a fruitful session, kindly be respectful and kind towards each other. By participating in this event, you agree to the terms and conditions listed in the registration portal. Last year, we made history with the website's launch, which is Singapore's first endometriosis official support and awareness website. Up to date, there are 54 published posts, which is equivalent to a weekly update with information and resource varying from endometriosis research to a list of endometriosis specialists to a contact list of holistic approaches such as acupuncture, physiotherapy, naturopathy, as well as a list of where you can get gluten-free options. These topics are just a few mentions out of the many others covered on the website. There were over 5,000 website visitors in the year 2021, of which more than 4,000 of them are from Singapore. These numbers are a motivating factor that keeps me going, knowing endometriosis is gaining traction. The first survey was also exercised, and the result was shared to fill the statistical gap relating to endometriosis here in Singapore. This year, we have the honor of having a Member of Parliament, Ms. Carrie Tan, gracing the event and standing united for the cause. Being an endo warrior herself, Miss Carrie begins to advocate on the disease, and I am highly grateful for the support rendered. Without further ado, let's hear it from the empowering lady herself, Miss Carrie Tan, please.
Hello, hi everyone. Thank you, Namira, for inviting me to this event. And well, maybe I can just introduce myself. I'm a member of parliament and of Nee Soon GRC, and my division is at Nee Soon South. And recently, Namira reached out to us, and it was with really pleasant surprise that to get to know her and to know that a woman out there, together with her friends and all the people in the support group, have gotten together to raise awareness about women's health condition. That has been, I think, going on for years, which I myself has personally suffered from since I was in my late teens. It's just that when I was growing up, there was very, very little awareness about this condition. And even when I was having very severe menstrual cramps each month, there was really no one who could advise me on whether that was normal And when I talk to, my mom, my mom would say things like, oh, you'll go away when you grow up and get married and have a kid. So I'm like, oh, okay, that's like a long time into the future when I was just a teenager. Um, I think things took a turn for the worse, or got really, really bad in my, I think it was about mid 20s, where for I think between my teenhood and mid 20s, I was constantly on painkillers every month. And during that period of time, my painkillers dosage increased. It started with like Panadol, and then increased to Panadol, and then it didn't work, and then I got other kinds of medication. And each time I went to a GP and said that the medication or the painkiller is not helping, they just gave me higher dosage or recommend another brand of painkillers for me. So this went on until I was in my, I think, mid 20s and in a corporate job. And for 2 months in a row, the pain got so severe that the painkillers were not working, and I literally blacked out. Like blacked out. I think the first month I blacked out, I'm like, okay, this is really bad. The pain was really bad, and I got very worried. Like, is there something else going on with my body or with my health? So the second month when I blacked out again, I basically, I think, called myself an ambulance, or I found my way to the A&E department. And actually, what they were able to do for me was that they put me on a drip and some painkillers again, and then asked me to go home when I felt better. And again, I didn't have any answers as to why was I having so much pain during my menses. So I decided to go to a gynecologist. I think the A&E department recommended I go to a gynecologist, and I did. And during the gynecologist visit, what was actually found out was that I had a cyst. I had ovarian cyst, and I thought, oh, okay, great, finally, I know what's been causing my pain, and I thought it was ovarian cyst. So I got booked in for a laparoscopy, a minor surgery to remove the cyst. And I think, to my shock, when I woke up after that, what happened was the doctor, the gynecologist, while removing my ovarian cyst, saw that I had endometriosis cells in my reproductive system. And she said that they took the opportunity to laser or burn away some of these cells. And I'm like, huh, what is endometriosis? And she basically explained that it was something about the uterus lining backflowing and then creating old set up cells and then stuff like that. And I'm like, okay, so is there any cure? And they weren't able to give me any solutions, except that it's a condition that is likely to reoccur every 5 years. And that at that time, because I was late 20s, right? She was saying, if you plan to have children, you might want to consider having them sooner, because endometriosis has high chances of recurring every 5 years, and if it does recur, it could compromise my fertility. So of course that sounded quite worrying, but I wasn't about to jump into a marriage and have kids just so that I will not have pain lah, or. So I think I kind of live with that as the backdrop of my life, and it kind of influenced I guess some of my life decisions as well, having this chronic condition. So that was my experience. And now, from getting to know Namira and E for endometriosis and having gone for several talks and events with them, I'm also personally deepening my knowledge about this condition. And I hope that, by being here and by helping to amplify these messages to women, and whoever you're watching now, all of you are with us now, do share with your friends, your sisters, your mothers, your daughters about this, to know that it is not normal to have such debilitating period pains, and we should have it checked out so that we can better manage it. And I very encouraged that right now the GP community, the doctors community are also rallying around this issue to help more women and help doctors pay more attention to help better diagnose this condition in women. So thank you to Namira and her team and everyone, all the stakeholders involved, for helping to do this awareness and outreach on this topic. Yeah. Over back to you, Namira.
Thank you, Miss Carrie, for the enlightening opening speech in the spirit of the event. Your advice has shed light on the importance of creating endometriosis awareness, and I hope many of us here will continue having this conversation even after the event, because the more we talk about it, the more we understand it is a real condition. Up next, Endo Explains. It is such a privilege to be working alongside Dr. Mali. She is the medical advisor in providing clarity on medical related inquiries for the movement. Her expertise in endometriosis is apparent, having made it to the international list of endometriosis experts in I Care Better after extensive vetting. I Care Better is an innovative platform dedicated to helping patients with endometriosis and chronic pelvic pain find compassionate and skilled experts. She also runs the endometriosis clinic in NUH, which provides comprehensive assessment and up-to-date treatments for patients with endometriosis. You may reach out to her in the Singapore Endometriosis Support Group on Facebook or drop her an email. Should you need to set a consultation with her, fret not, I will be posting the details on all my social media accounts by tomorrow. So if you have yet to follow me on any of the platforms, please do so. Search for E for Endometriosis or Endo Support SG. Passing the event to you, Dr. Mali, please.
Thank you very much, Mira, for the kind introduction. And thank you for inviting me for the talk. I think is for the endometriosis support awareness campaign is the 7 or 8 years that I've been doing this. And I feel I'm very privileged to get to know Namira in this awareness campaign. And over the past few years, we have been collaborating and try our best to increase the awareness of this condition. And we can see from the response of social media, from the response of the public, more and more people get to know about this condition. More and more people are actually coming forward to ask doctors whether I do have this condition. So it does shows the effort that we have been working on finally paid off. But I know it's still a long way because even in the clinic consult, I still hear a lot of misconceptions about the understanding of endometriosis. So today, I will just share some of the information about endometriosis, because try to correct some of the misconceptions that we have for the past many years. So today's topic will be more on common pitfalls on management of endometriosis. There will be some surgical photos which it might be a bit sensitive. So if you have any concerns or anything, you can communicate with us. So we all know that endometriosis are very common, affects about 10% of women of reproductive age, but actually over the past few years, the incidence of endometriosis is also increasing. And especially in patients with subfertilities, about 30% of them are actually due to endometriosis. Again, for women with painful period, about 40 to 60% of them are actually diagnosed as endometriosis. But again, although this disease are so prevalent, the awareness of this condition among primary caregivers has remained low. That's why there's an average delay in diagnosis of 7 to 8 years from the onset of symptoms, which is quite sad because delay in diagnosis of endometriosis would also end up with more damaging to organ functions, including fertilities, including damaging to surrounding organs. So what is endometriosis? In older days, or maybe when you're discussing with the doctors, I think Carrie also shared just now that the doctor was explaining that endometriosis, because of the menstrual blood or cells from the lining of the womb, flows back into the tummy. But the truth is that actually with the progression of the scientific research and everything, we realize that this is different from retrograde menstruation. Retrograde menstruation does not explain the 100% of the endometriosis. So although the cells in endometriosis are quite similar to the endometrial lining, but actually is completely different in regards of its ability to invade into the other organs, ability to cause inflammation, and also ability to cause scarring. All these are very different, are worse than the normal endometrium that lines the uterus. So again, just a normal, simple anatomy of the female organs. So this is the uterus. So this is the lining of the womb. So the pink one are the cavity of the uterus where when having a period or when we get pregnant, baby will grow from these cavities here. And these lining are called endometrium, which is lining which is lining that cover the inner lining of the womb. When we have period, this lining of the cells of the lining would shed out and form the menses. This part is called myometrium, which is the muscle layer of the uterus. And outside there is this layer called serosa. This is fallopian tubes, which function as a passage for sperms and eggs. And this is the ovaries that is producing eggs and producing female hormones as well. So again, in older days, we think that the endometriosis occur because this part of the cell actually retrograde goes into from the fallopian tube and goes into the abdomen. Yes, it does happen. When we do surgeries, we do see that sometimes the menstrual blood are present in the abdominal cavity. But research does shows that endometriosis are very different from retrograde menstruation because the cells are very, very different. They tend to have more properties of causing inflammation and scarring. So the theory is very important. Why is that? Because it actually affects how we treat endometriosis and how we manage endometriosis. And again, endometriosis is much more than just ovarian cyst, because among all patients with endometriosis, only 20% of patients have endometriotic cyst. That means about 80% of endometriosis actually are present elsewhere and affecting more other organs, causing more severe problems than just a simple ovarian cyst. So this is the some of the surgical photos that we see during laparoscopic surgeries. So this is a normal pelvis where you can see uterus. This is the fallopian tube, and this small whitish one is the ovaries hiding behind the tubes here. And this part is a uterosacral ligament, which is a supporting ligament of the uterus. And here is the rectum, sigmoid colons, where you can see all these organs are very nicely separated from each other. They don't touch each other, although they live coherently with each other. So again, we can see here for endometriosis, these patients do not have a cyst. But again, because of endometriosis, all these organs compared to this one are kind of adherent to each other, can plaster to each other. So again, the bowels was adherent to the uterus. And again, you can see bladder was adherent to the bladder is in the front, which is also stuck to the uterus. And again, laterally, you can also see, which is normal, the uterosacral ligament and side wall here, which is also drawn inwards by endometriosis itself. So it's not easy, it's not difficult to understand why endometriosis patients have so much pain, because all these distortion of the pelvic anatomies, which are causing the distortion of the nerves, trappement of the nerves, blood vessels, and all these important organs. This is the reason that it causes pelvic pain. So it's not only because of the cyst, but rather it's because of the distortion of the anatomy that caused the pain. So where is endometriosis coming from? So coming to the theories of why it happens. So we used to believe that it's because of retrograde menstruation, but now we more believe that because of the property of the cells are different, we think that all these cells from endometriosis are possibly already there during fetal development. Means that when we're already a fetus in our mom's uterus, the cells, due to development issues, the abnormal cells are already deposited along those organs. And again, with our menses coming, with the female hormones stimulating, all these diseases, all these cells that are already present in these organs start to respond to hormone and start to cause fibrosis, cause bleeding, cause scarring around it, in which will cause worsening problems and worsening pain. Again, there are other theories which we think that some of the cells may change from one cell type to another, or some of the cell could be developed into the glands or stroma cells. But now with more and more endometriosis doctors believe that the endometriosis is actually coming from the first one, which is the Mullerian deposition, which means that these cells are already present, or these diseases are already present when we are actually a fetus or embryos, actually. So, and again, endometriosis is not only a gynecological condition because it does not only affect ovary, it does not only affect fallopian tubes or uterus, we do see actually in about 70 to 80% of the time, the pain comes from other organs, because endometriosis can be present basically in any part of the body that you can imagine. Most commonly, it can affect the bowels, can affect the pelvic nerves, can affect bladder, or can affect ureters. And in severe cases, it may actually go to the lungs. We've seen people quite often which presented with chest pain whenever they have period. And also we have patients who have endometriosis at the liver. And recently I have a patient who have endometriosis at the cardiovascular sac. So all these does prove that these are the theories that cannot be explained by retrograde menstruation because it is not connected. So meiosis does explains why all these organs do present with endometriosis. And again, the symptoms from endometriosis do depend on where the endometriosis are exactly located. So it's not only menstrual pain. It due to, if, like for example, if the bowels are affected, the symptoms might be more cyclical bowel symptoms. So quite typically, some patients may experiencing diarrhea at the time of period, or when they go past motion, they feel cramps or feel severe abdominal pain, or during sexual intercourse, they have severe pain. And some patients, as I mentioned just now, if the endometriosis are present in the lungs, they will have a perforation of the diaphragm in which they presented with pneumothorax at the time of period. So it can present it with wide range of symptoms, basically depends on where the endometriosis are present. So it is not difficult to understand why endometriosis management have to involve many different subspecialties, because it is not only gynae that is involved. We have to see, of course, endometriosis is a gynae condition. Gynecological doctors should have the abilities to diagnose, to see where the endometriosis are, and subsequently we have to involve the corresponding subspecialty doctors, for example, colorectal doctors or urologists. Sometimes we need a pelvic physiotherapist to help with the post-operative pelvic rehab. And again, we need dietitians. And again, because we know that chronic pelvic pain do cause a lot of mental problems as well. So psychological support is also very, very important. And again, involving pain team to optimize the kind of pain controls to these patients. So involve a very wide range of disciplinary doctors to help with our management of endometriosis. So here I want to talk about this severe type of deep infiltrating endometriosis. It's a more severe types of endometriosis, affecting about 20 to 35% of all patients. Most commonly, we do see that endometriosis growing into the bowels, growing into the vagina, or growing into the ureters or bladders. And quite commonly, it is one of the common reasons why patients have severe pain. And if the doctors who are seeing the patient is not experienced with dealing with deep infiltrating endometriosis, if they do a scan, okay, see there's no endometriotic cyst, no ovarian cyst, they would tell the patient, okay, you don't have endometriosis. That's one of the very common reasons why the diagnosis of endometriosis are delayed, because for these specific kind of deep infiltrating endometriosis, it is not a big cyst that is present in the ovaries. It is actually a solid nodule growing into the surrounding organs like bowels, like ureters. And these are the ones that are really actually causing organ damage and have to be diagnosed early. Otherwise, they will cause more damage to the organs, in which may cause kidney function loss or even bowel obstructions, etc. And even at the time of the surgeries, because all these disease on the surface, it might look very, very mild, but actually, if we do a proper surgery, most of the disease are actually buried underneath. So if we need to do a surgery, you need to find correct doctors to do the endometriosis surgery, because only the doctors that are experienced in dealing deep infiltrating endometriosis, those are the ones that actually can diagnose and can treat deep infiltrating endometriosis properly. So how do I know that whether we have endometriosis? So again, painful period is not all. So I think all of us knows that endometriosis can affect every part of the body. So of course, it may not present with only painful period. So it depends on where the endometriosis are present. You can have cyclical menstrual cramps pain, or even at the time when you're not having period, may also have non-menstrual pelvic pain, can be cramps, can be sharp pain, can be shooting pain, can be, some people may feel like constant pressure over certain areas. And also some patients may have pain during sexual intercourse or bowel problems like cyclical diarrhea, constipation, or urge to go to toilet pass motion at the time of period, or pain when passing motion. Again, commonly we do see some people may have constant lower back pain or lower limb pain, including groin or sciatica. Those kind of very typical shooting pain over the lower limb because of the nerve involvement. And again, if the endometriosis are affecting the diaphragm or upper body, some people may have upper chest pain or upper back or shoulder pain. Ovulation pain happens if there is adhesion or scarring around the ovaries, or flank pain or nerve pain. Again, infertility is also one of the common symptoms for endometriosis. About 30 to 40% of the patients with endometriosis do have infertility issues, actually. So actually, in this website that we built with Namira, we actually designed questionnaire together with the help surveyor to have an endometriosis symptom quiz. So in which they listed out different kinds of symptoms for endometriosis, where you can click the choice, and then in the end of the quiz, we have a scoring to tell you what's the likelihood of having endometriosis. And if you have most of the symptoms, it is highly suggestive, in which case you are suggested to see an endometriosis specialist to get diagnosed and get intervention early. So how is endometriosis diagnosed? So again, it is not only so no cyst does not mean no endometriosis. And again, this is one of the very big reasons why endometriosis diagnoses are delayed, because a lot of people do things that, okay, you don't have a cyst, then you don't have endometriosis, which is wrong. And again, even for the latest endometriosis guideline that was published in 2020, we no longer use laparoscopy as the diagnosis golden standard for endometriosis, because we don't actually need a surgery to diagnose endometriosis. We have very reliable way of doing ultrasound scan to diagnose before going for treatment. So don't always rely on laparoscopy or surgery to diagnose. The purpose of the surgery is for treatment, is not for diagnose. And again, before you do treatment, we need to have a very complete diagnosis of endometriosis, whether it is endometriosis and where is the endometriosis located. That means the mapping of endometriosis. So in NUH, we do use this scoring system. So when we're doing other endometriosis scan for the patients, we do look at many different areas. So with a simple transvaginal scan that we normally do in gynae clinic settings, we can assess different parts of the body, including not only uterus, ovaries, but also including, we have to assess kidney, bladder, ureters, of course, uterus, ovaries, and whether there is any adhesion or scarrings around the ovaries, whether there is any pain when we're doing ultrasound scan. More importantly, we look at the back, including we have to assess the vagina, have to assess the layers between bowels and vagina. Also need to assess the bowels, assess the ligament of around the uterus to see whether you do have endometriosis. And this scoring system actually are designed by an Italian group of doctors in Italian, and then it has been worldwide have been widely used as ultrasound scan report form. So I think when we're looking at the ultrasound scan report for endometriosis, when you are giving a report for endometriosis, it's also important to look at what are exactly reported in ultrasound scan. So a complete endometriosis mapping scan report should include all these listed items, not only to tell you, okay, uterus, what's the uterus condition, what is the ovaries condition. They have to tell you, more importantly, the bladder, ureter, whether it's affected, and also whether there is any nodularities in the bowels, whether there's any nodules that is invading to the ureter, into the bowels, or any sigmoid colon. So all these important organs. And again, these have all these factors have to be included in a complete endometriosis scan report. Again, once it's diagnosed, how to treat. Again, there's a lot of misconceptions about the treatment of endometriosis, and the concept of treatment of endometriosis have evolved quite significantly over the past 5 to 10 years' time. So do I need a surgery? Again, treatment is different. Depends on which organ are affected by endometriosis, whether it is a cyst in the ovaries, whether it is deep infiltrating endometriosis affecting organs like bowels or ureters, whether it is endometriosis affecting uterus, which is adenomyosis. And again, treatment also are different, depends on whether the treatment purpose is for pain or for fertility. So again, in older days, we quite commonly, when a patient was diagnosed as a cyst on ultrasound scan, or they strictly went for surgeries to remove the cyst. But over the years, we have found out that actually not all cysts need a surgery. We have to factor in a lot of different problems, because for cyst, it's only a small part of the endometriosis treatment. And again, cyst surgery, although it's simple just to remove the cyst, but it does carry out a lot of implications. Because when surgeons are doing the cystectomy, where removing the cyst, unavoidably, there will be some follicles, means the eggs from the ovaries, that will be removed during the procedure of removing the cyst. So it will actually reduce the ovarian reserve. And again, ovarian reserve is a kind of like pool of eggs that we have. So this pool is fixed number of eggs, unfortunately, when we're born. And each time when we have a period, there will be one batch of the eggs that disappear from this pool. And once this pool finished, we are considered menopause. So this pool is fixed. Again, endometriosis cyst would affect the quality and number of the eggs. But again, doing surgeries would unavoidably reduce this pool of eggs. So that's why it's important to choose the correct timing for the surgeries. Not like, okay, we see a cyst for a young girl, we do the cyst. And again, a few years later, come back, again, we do another cyst. The outcome of this kind of approach is that it will reduce the ovarian reserve quite significantly, especially if the cysts are big on both sides of the ovaries. And then if we do repeated surgeries for young girls before they're planning for fertilities, we'll reach the stage where the ovarian reserve is so low, they will make the fertility even more difficult. Even with IVF, it will be difficult because the response of the IVF are heavily dependent on egg reserve. So when IVF doctors are giving stimulations, giving medications, the number of eggs that they can stimulate it are heavily dependent on the pool of the eggs that we have. So if the pool already very low, and even with the highest dose of stimulation medications, the IVF doctors will not be able to get enough number of eggs for IVF purposes. So that is the problems of the surgery. But again, surgery does increase natural conception in all stages of the disease, especially immediately after surgery. So how do we choose the timing of the surgery? So we look at the age of the patients. We look at the patient, whether they have any fertility problems at the time when they are diagnosed, and their baseline ovarian reserve. So whenever we see a young patient who have not completed families with the ovarian cyst, the first thing we do is to do an ovarian reserve test to see what is their baseline ovarian test. If the baseline ovarian reserve is already very low, then we know that surgery will actually cause more harm to the ovaries, then their fertility will be affected. Then these are the cases that is not suitable to go straight for surgeries. These are the patients that we have to try with medical treatment to suppress the endometriosis as much as we can, because most of the endometriotic cysts do respond to hormone treatment pretty well. So we monitor them, and once they are ready to conceive, we encourage them to try naturally, or let's see if they really have fertility problems, they really cannot get pregnant. This is the time that we should go in for surgeries. And again, if their ovarian reserve is still low, or if the cysts are big on both sides of the ovary, we also have to discuss with them whether they need to go for fertility treatment first, whether it's IVF or IUI first, or go for surgeries first. This is a decision that we make together with fertility doctors in the aim of improving their patient's fertility outcome, and also in the aim of controlling the endometriosis better. So this is one of the quite common misconceptions actually a lot of doctors have. So I do hope that right now we do hope that public understands that not all cysts need the surgery immediately. We have to choose a best timing for the surgeries in the aim of protect the fertility and also in the aim of avoid repeated surgeries. For example, this is a patient that we see, quite a sad case. She's quite young, but unfortunately, she had a previous 4 surgeries for endometriotic cyst. She had one at the age of 19, and again, a few years later, the cyst come back, they're waiting for another cyst, another surgery. So in total, she had 4 surgeries. But again, she's still having persistent pain, but she's still keen for fertility because she's just got married. That's when she come to see us. During the examinations, we do notice that, again, the cyst comes back. So we did ovarian reserve test. So this is called anti-mullerian hormones. Unfortunately, it comes at 0.2. This one normal should be actually above 10. Below 4.5 is considered extremely low. So her level is actually similar as menopausal range. So that means even with this level, if we give her IVF, very likely that even with IVF, she may not be able to get any eggs at the time of stimulation. So here we are reaching a very difficult dilemma. So first we have to solve her pain, and there is a recurrent cyst. On the other hand, we have to break the news to her that the fertility part are gonna be a very, very difficult decision. So I do hope that by giving these talks, I do give this kind of talks to medical professionals as well, to try to emphasize the point that don't go for surgery just for the cyst itself when the patient is very, very young, in order to prevent this kind of problems from happening. So when do we need a surgery? So that's when we're doing endometriosis mapping scan, when we find that endometriosis is already causing organ damage. That means if the endometriosis is already growing into the bowels, growing into the bladder or ureters, which causing potentially blockage of the kidney, or if lastly the pain does not respond to hormone treatment and there is scarrings or adhesions or deep infiltrating endometriosis in the pelvis. These are the ones that we do need to go for surgery for the purpose of releasing the pain. And again, for endometriosis patients with, some of them do have difficulty to conceive, then we have to discuss them based on the few factors that we have to discuss whether we go for IVF first or go for surgeries first, or if there's any obvious signs of suspicion for malignancy. These are the patients that we do advise for surgery, and the surgery should be quite aggressive to mainly aims to excise the endometriosis completely. So the first surgery is always the most important because there are different kind of surgeries, whether it's keyhole surgeries, robotic surgery, or open surgery. But I think in our experiences, laparoscopy surgery is much better than open surgery. I'll explain the reason why. So in laparoscopy surgeries, because the cameras can go into the pelvis and can go very, very deep into the pelvis. Because here we can see, this is the uterus. This is behind the uterus. So most of the endometriosis disease are behind the uterus. So again, with the advantage of scopes, laparoscopic surgery is that because the camera can go into any angle in the pelvis, which is very, very deep in the pelvis. If we can see the disease, we can do a very fine dissection. So again, because of the laparoscopy is a magnified view, we can see the disease better, we can do a very fine dissections, and at the same time, we can also dissect all those important organs away very, very precisely in order to preserve the nerves, preserve the important organs. So laparoscopic surgery does provide the advantage of very superior view of the pelvis. In a way, it is very important for this to achieve the purpose of a complete removal of all disease. Whereas for open surgeries, it would be very difficult because you can see from this comic that, I mean, it is a comic, but it's very, in a real situation, it's like this. Patient lie on the table and surgeons stand around. Surgeon's eyes, at least there will be 40, 50 centimeters away from the pelvis. So the surgeon will not be able to visualize the disease that well, especially if all the disease are hiding behind the uterus. We won't be able to see the disease at all. So if the surgeons cannot see the disease, how to make sure that we remove the disease completely? So open surgeries is never recommended for endometriosis surgery. And again, especially with the current technologies, we have various different forms of imaging systems that can help us to visualize endometriosis. So this is narrowband imaging, which are with a very special light beam. We can see all these endometriosis spots being highlighted compared to the normal vision. And again, we do have high D vision. We do have 3D technologies at the time of the surgeries to help the surgeons operate. So endometrial surgery, there's two types of surgery: ablation, which is burning, versus excision. So what's the difference? Ablation is just to see the disease on the surface and also just burn whatever disease is on the surface. Whereas for excision, we have to get to the root of the problems and then take out the disease completely. So the difference is that for ablation or burning, of course, the risk will be low because it doesn't involve all the dissections of the disease. The recovery will be faster. You may feel not much of difference actually after the surgery, not much pain. But again, the problems is that the recurrence rate is extremely high. It actually doesn't treat the endometriosis that well because it's just burned whatever is on the surface. Actually, the true bulk of the disease are at the bottom, which is so whatever is burned is just on the tip of the iceberg. It doesn't solve the problems at all. So for example, this is the surgery that we did recently. So we can see on the surface, it looks pretty okay. There's no adhesion. It appears that there's no adhesion at all. So if we just do ablation, very likely only this few spots that will be burned. But the problems of this patient is that actually she has a very big bowel endometriosis underneath. So when we do dissections, we do dig deeper. This is the big bowel endometriosis that has already invaded into the bowels. So if we don't do excision, there's no way that we will be able to remove this disease completely. And then after the surgery, if we just do ablation or burning, this disease will continue to cause problems. The pain will not be resolved and the disease will continue to progress and causing more problems. So again, that's another one. Also, a recent case that we did, which is quite severe. So on the surface, it also looked good, but when we're actually dissecting all the ways, we know that this patient, although on the surface is just a spot of disease, but what is underneath is more important. This disease has already, this is the ureter on the left side. So this disease has already invaded into the left ureter and causing damage to the kidneys. You see, this tubular structure actually is a ureter, which is very, very dilated compared to its normal size. So these are on the surface looks nothing actually. So we can only know if we do an endometriosis mapping scan. We can only know if we do a proper excision surgery. Then we know the extent of the disease. So that is the key for complete removal of all the disease. So incomplete surgery or ablation surgery, what is the consequence? It causes persistent pain. It doesn't treat the pain at all. It causes progression of the more severe disease. And again, repeated surgeries and incomplete excision. So there's a few pictures. I put it here where you can see this is a CT scan of two. These two are actually kidney. Both kidneys are severely damaged, like a balloon now here, because of the ureter endometriosis not being treated previously. So both kidneys are blocked. And then another one, this is a disease that actually invaded into the major vessels that cause repeated blood clots in the lower limb. So another misconception that we often have is that quite commonly some patients were told, okay, you have pain, we'll do a hysterectomy for you, and then your pain will be gone, which again is not true. So when we look back from our basic theories of endometriosis are not only present in the organs, we have to see where the pain is coming from. It's not like we have pain, then we do hysterectomy, removing the uterus, the pain will be gone. The hysterectomy that can treat pain only if the pain is coming from the uterus only, which is adenomyosis. Yeah, but if the patient does have endometriosis elsewhere, and those are the ones that causing pelvic pain purely by removing a uterus and leave a lot of pelvic disease inside, it is ineffective and it will not cure the pain at all. So another case we had lately, so similar, so she's 41, she had a previous removal of the uterus in 2015. So a part of the uterus was removed, but again, the pain didn't change at all after the surgery. She's still having cyclical pain, and she has pain during sexual intercourse. She has pain when passing motion, and also always have the urge to go to toilet pass motion. Now, when we did a scan, quite sadly, we noticed that the patient's left kidney has already been affected. The left kidney is dilated. There is a disease growing into the ureter on the left side. There's another disease growing into the bladder. There is also another disease growing into the bowels. So the extent of the disease is quite extensive endometriosis. So we have to go in for very, very long surgeries, basically to cut off part of the ureter and reimplant the ureter, and then cut part of the bowels and then do bowel anastomosis. So all these we do shows that a complete and proper surgeries for endometriosis is very, very important. And again, another misconception that we often had is that many patients were told that, okay, your endometriosis will be cured after menopause, which again is not that, it doesn't happen that commonly. It doesn't happen that commonly because a lot of endometriosis, especially for deep infiltrating endometriosis, they actually causing damage or more fibrosis around the disease itself. Again, some of the disease itself do produce their own hormones, regardless of the status of the ovaries. And these are the ones that possibly after menopause may not be cured. And again, there is a 2% risk of cancer change for endometriosis around the age of menopause. So for our patients that follow up in our endometriosis clinic, even they go menopause, we do follow up with them quite regularly. And again, if there is any red flag signs, that means if you are suddenly experiencing a change in habits of urinary habits or bowel habits or severe abdominal pain or bloatedness, it's always important to check with the doctors and do a scan to see whether there is a change in the pelvic endometriosis situation. So fertility is another big topic. Surgery versus ART. ART means the artificial reproductive technology, means like IUI or IVF. So again, the value of surgery is quite debatable. If, let's say, if the patient is low, ovarian reserve is low, or age is slightly on the higher side, then we might actually recommend patients to go for IVF treatment first rather than go for surgeries first. In some special situations, for example, if there's any like swollen tubes at the time when we do scan, or let's say if the ovaries is very high, that the IVF doctors may not be able to get eggs from below, or repeated failed IVF cycles. These are the ones that we will do surgeries to help with the IVF doctors also, to help with the fertility chance. So again, surgery may actually improve natural conception rate. So for young patients who may have a long time, enough time to try to conceive, and if the ovarian reserve is good, and then husband sperm quality is good, tubes are okay, then these are the ones that we might consider doing surgery. And after the surgery, immediately try to conceive after the surgery. So another thing is that not all chronic pelvic pain is endometriosis. So we in our back of the mind, we always have to think about other problems apart from endometriosis. For example, pelvic congestion, irritable bowel syndrome, interstitial cystitis, which is a bladder chronic inflammation problem, so any scarring adhesion. So all these actually scan can give a very good differential diagnosis to pinpoint exactly where the pain is coming from, and what is the origin of the problems are, because not all these conditions require surgery. Some of them actually with medication or physiotherapies actually will be able to treat the pain completely. So we really have to know what is the root cause of the pain and how to treat this pain. Yeah. So with this, I think a few points that I want to let us remember is that laparoscopy should not be used purely for diagnosis. And again, ultrasound mapping scan is the first line of diagnosis. And when you look at the ultrasound scan report, is specifically for endometriosis, there's those lists of the things that need to be included in an endometriosis mapping scan. Having a cyst does not mean that you'll need a surgery immediately. And when it comes to the surgery, always find a surgeon who can do excision surgery, who can aim for a complete excision of all the disease, so that you can maximize the outcome of the surgery, can really relieve the pain, and also reduce the chance of recurrence and reduce the risk of having to go for repeated surgeries. And again, hysterectomy does not cure endometriosis, and the first surgery is always the most important. So I think there's a few groups that we can go for information. Namira does set up a Singapore endometrial support group, and we also have this endometrial support, endosupport.sg. To find the doctors, because I Care Better is quite good, because it does not only include gynecologists, they also have physiotherapy, psychologists on board. So they will verify, it's a very stringent verified process to make sure that these doctors really know what they're doing and really treats endometriosis professionally. So with this, I will finish my lectures, and I will welcome if there's any questions, you can drop me an email or just join our support group, or actually can contact Mira also. We're all here to provide full support for every one of you here. Thank you very much.
What an informative presentation. I, for one, am getting a lot of insights from such an educational session. Thank you, Dr. Mali, for yet another thorough session.
Thank you,
Before
Mira.
we proceed to the next segment, let's take a couple of minutes for a polling session where 9 questions will be put up for evaluation. This would allow me to understand your concerns and the topics I should prioritize, and having this information would be very helpful for me to plan out future initiatives for you. So I am launching the polling now. Okay. All right, I will end the polling session in 2 minutes. So please do participate.
Hi, Namira. Hi, Mali.
Hi. We are currently launching a poll, and we'll start with the next segment in just give around a minute time.
Okay, I'm right on time.
Yes, you are.
Thanks for coming, Annabelle.
No problem. Thanks for having me. Sorry, I couldn't make it earlier.
No
I'm
worries.
here now.
Yes, that's the most important thing. Okay, everyone, I will be ending the polling soon in around 30 more seconds. Please do participate so I'm able to plan out future initiative accordingly for you. Okay, I'm ending the polling in 5 seconds. 4, 3, 2, 1. All right, thank you very much. And here's sharing with you the result. I can see 97% is from Singapore. That's interesting. There's 3% from India. Hello, hello. All right. So most is heard about this event from Singapore Endometriosis Support Group. Yeah. And okay, 70% is diagnosed with endometriosis. 20% is actually suspect that you might have endometriosis. So hopefully from this session, you will be having a better understanding, and most importantly is to get yourself checked by an endometriosis specialist, okay? Okay, number 4, extremely important. Yes, I also think that it's very important to create awareness. All right. Okay, I will put this into consideration. Afraid of being judged. Yes. Endometriosis awareness is not just about making people aware of it, but it's also about debunking and also challenging the societal expectations and stigmas. Okay. All right. I can see most of you have yet to take the self-assessment endometriosis questionnaire. It's actually available on endosupport.sg, especially for those who are still uncertain of whether you have endometriosis or not. Perhaps that questionnaire will be able to assist you with that. So I would encourage you to, just take the questionnaire and find out more. Okay, if yes, it's good to know 27% actually get a consultation with a doctor and get properly diagnosed. That's great. That's great to know that the questionnaire is, helping you with this. All right, good to know that you are finding the support very helpful and essential. Okay, I understand. All right, more sharing sessions on pain management. Okay, nutritionist advice. Understand. And finally, financial assistance. Yes, education curriculum. All right. All right. Thank you very much. I'm very grateful of the feedbacks and the honest response here. I will put this into consideration. Thank you very much. I will stop sharing. And in the next segment, we have endomental health. We have Dr. Annabelle, who is the principal clinical psychologist at Annabelle Psychology. Dr. Annabelle strongly believes that the needs of each individual are unique and different. This philosophy is reflected in the careful selection of therapy and her relational approach tailored to each individual need. Her interests cover personality disorders, trauma, abuse, as well as grief and loss. These issues hit home for someone who faces a lifelong illness such as endometriosis. Tips and piece of advice in overcoming this emotional distress would be very valuable. Let's not anticipate further. Here's welcoming Dr. Annabelle. Over to you.
Thank you, Lady Boss Namira. Thank you, Mali, for inviting me to join all of you this Saturday afternoon. My apologies that I could not be here at 2 o'clock, but I'm here now. Okay, let me start by sharing my screen first, and maybe you can let me know if you can see my screen.
Yes, Dr. Annabelle, it's all good.
Yes. Okay,
thank you.
Great. So I won't go too much into myself, but Namira has shared, I'm a psychologist at Annabelle Psychology, and actually in my work I do see a lot of women with health conditions as well, and sometimes they may not actually even know that they have to consider a potential diagnosis of endometriosis. So I was actually very excited when Mali invited me to be part of this today. Okay, so just a little bit about what I might be covering to see if that also fits with what you're looking for. I wanted to share a little bit about the challenges that women face with endo, and some of the ways that I think could be helpful in managing the challenges that present with endo. And I noted that there are no family members today, but I thought it might be also helpful to just kind of look at how family can support in terms of like what we can also share with them, what they can say or not say, and how they can provide the support to us. But more importantly, before that, I think it's like, how do we ask for help? And how do we get our family to actually support us in a way that still helps to support our individuality and our independence with compassion? Okay. I won't actually go too much into detail about the challenges with endo because I believe that the audience here, you would probably be very familiar with the pain that you experience, the abdominal pain, the possibility of infertility and all the symptoms related to that. But I thought what I might want to focus a little bit more when we talk about frustration with endo might actually be more about how there is a lack of awareness, unfortunately, that not only does the public not really know so much about this condition, I think a lot of times the sufferers themselves may also not be very aware of this. And when we don't have sufficient awareness, it also means that we wait a long time before we go see an OBGYN or a doctor to get it diagnosed. But the frustrating thing is when you then decide to go see one of them, the wait time is also very long to see them. And then the wait time is also very long that to finally get a diagnosis. And I can see Mali nodding her head there, right? So I read a piece of research where they said that the average wait time for a diagnosis is actually about 8 to 10 years. And I was pretty shocked by that as well, because that is a really long time to have unexplained pain and discomfort without yourself really knowing what you're experiencing. And when you don't know that, you can't really communicate that effectively and get support from your family as well. And the truth is, unfortunately, I think a lot of doctors are also misinformed. I don't think that even in the context of Singapore, there are a lot of medical experts specific that their interest is endo. And Mali is actually one of the rare few that you need to make sure you have her contact details. But when the doctors themselves are misinformed, I think it also results in kind of a bit of a merry-go-round when it comes with wrong diagnosis and wrong medications before you actually get correctly diagnosed. A little bit like mental health as well. Like a lot of times my patients who come into me, who come to the clinic, they may have been misdiagnosed with something else. And then through careful assessment, then we realize that, actually, according to my experience, I don't think that's what it is only. And of course, the pain will affect our ability to be productive, both at work and at home. And that's very debilitating because it's not so much just office hours and you're done. But, of course, when you get home, you cannot really function so well when you're in pain. You cannot really do housework and do cooking and the, everyday affairs. But, if you have to look after other family members like your elderly parents, or if there are little kids at home, that also affects your ability to be productive. And that itself is very frustrating. And of course, the infertility rate is anywhere between 30 to 50%, which is a very high percentage to have to deal with. And naturally, I think whenever it comes to any kind of women's health conditions, It's very interesting, but it's actually oftentimes perceived to be a taboo topic. And even in my clinic, when my patients share with me about something in relation to their period, very consistently, I notice that they will start to lower their voice, and they will start to feel a bit embarrassed to share that, there's something about their period, or there's some discomfort, or, sometimes if they are able to share it with their family members, they might just be written off and dismissed that, oh, that's just stress. You just have to rest and then you'll be better. And that can be very isolating and a very lonely experience, and very scary, right? I wanted to kind of help make sense of this experience, and I oftentimes think of it in a grief cycle. So traditionally, the grief cycle doesn't actually really look like that. Traditionally, it looks like it's a more linear stage-wise, when we talk about grief, where it starts with you start with denying the fact that there's something wrong with you, or you have a condition that needs to be treated, or that it is actually diagnosed with endo, and these are the potential consequences of it. And then sometimes that might lead into anger, like, why me? So many people, what have I done to deserve this? This is so unfair. And you might kind of also have that despair and sadness of like, why me? Of like all the people, and feeling sad that you might, your life is affected in ways that are different with other women and other families. And you might also go into the bargaining state a bit, where you start to try to make sense of your experience by talking to people, by joining support groups, by trying to find more information about it. And lastly, finally coming to terms with, okay, I have been diagnosed with this, and I need to think of a way of how I am going to make some adjustments in my life, so that I can still live a life that I want, that I can be happy about, and I can feel fulfilled about, with this condition in the background. So it's not a linear, stage-wise grief cycle. I want to highlight that. You can sometimes be in denial, then you can sometimes feel really sad. You can sometimes feel angry, and then you might have a moment of acceptance. Then you might kind of bounce up and down. But it's the more that, the bigger the window you are in acceptance, and the less you bounce around, that means that you are more accepting of the diagnosis. But grief also has no timeline and no specific form. It's just different for everyone, and the truth is, there's just no textbook that is really able to pin grief down very neatly, because everybody grieves in very different ways. So the recommendation that I would offer is to be kind with yourself, and there's no specific timeline that you can or should put to grieving when you get a diagnosis. Yeah. Okay, so what I think might be helpful will be a few things to think about. So the concept of radical acceptance is often, actually, to be honest, a very difficult one to stomach, because my patients will say, what, you're just telling me to accept it? Like, I have no choice. And it's just very difficult to take on this term of acceptance. If the word acceptance is very triggering or very difficult, you can consider using alternative terms like letting go, making space, or kind of being gentle. But I want to kind of talk I want to talk more about what acceptance really is defined as, in the sense that for those of you who wear glasses, okay, Mali is a convenient one for me to use. So Mali, you wear glasses, right? And every morning when you put on your glasses, do you fight the fact that you have to wear your pair of glasses, and you feel irritated and you feel angry? Oh, Namira is glasses too. And you feel frustrated, and you feel like, oh, why did I watch the TV so near? And why am I like having to wear glasses now? And then there's this whole thought process. Does that happen?
Yeah, I think I'm still in the denial and angry phase. How come I cannot wear fake eyelashes because they keep sticking into the glasses?
You and me both. So there's a separate conversation, right? We cannot get our fake eyelashes to stick on our eyelids. Okay, but yeah, and that's the thing, right? We don't accept that. We don't accept that that is something that is just not working for us. Oh my gosh, it's such a funny conversation. I was just telling Mali, I was just trying to put it on a couple of days ago, and no matter what I did, it just kept coming down, and I realized my frustration building. So in the example of the glasses, right? If you actually wear your glasses and you don't feel anything, right? And then that is the true form of acceptance, right? You just don't need to deal with it. There's nothing that you need to say to yourself to feel better, or nothing you necessarily need to do like breathing or centering to feel better, because you just accept that glasses are there to correct your vision. Just in the same vein, like if it's raining now, it's not raining where I am now, but if it's raining, some of us might get really angry and frustrated that, I'm going to get wet. It's so inconvenient. Grab fares will go up. And then they start to get into this whole process where they're very angry, but it doesn't change the fact that it's still raining and you will still have to think about how you manage the situation. So acceptance would be allowing ourselves to still feel all these difficult emotions that we oftentimes might try to suppress or push away. And these emotions are more arising from the challenges with the condition and the diagnosis, but allowing the emotions to come and go. So we make some space and we accept that, hey, of course, this is a difficult diagnosis to accept, and pain is not pleasant. And of course, I will feel frustrated. And think of the concept like emotional surfing, which is a little bit like sea waves at the beach, right? So if you think like you have a big wave coming, and then you think, maybe I should like push the wave away, or I should like hit the wave. Chances are you're going to be slapped back to shore, and it's going to be very, very painful for you. But if you turn your body and just surf together with the wave, that can be almost exciting and fun, and have a different perspective to say, I can actually make space for this experience, and the big wave will hit the shore and become smaller ripples and smaller waves. So acceptance is nothing like tolerance. It's not putting up with, like, okay, I'll just, no choice, I have to just deal with it. Like, that's not acceptance. And it's not kind of bluffing ourselves and like talking ourselves into just being okay with it. But acceptance in that true form is, it is what it is. Just a bit like COVID, right? It is what it is, and we have to learn to adjust our lives accordingly. We could kind of learn to also be more observant of our thoughts, our physical sensations, and our behaviors, because oftentimes these are, how we think about things will affect how we feel and how our body reacts and what we do about it. So for example, if I start to think about endometriosis in a way that, oh my God, my life is over, I can never have kids, and my life is just, there's just no hope because I cannot work, I cannot function at home, and I'm irritated all the time, my life is just doomed. And I think anyone who thinks that way is likely to feel sad and frustrated and helpless. And when you feel all this, your body will naturally react in those ways, right? Like you'll feel tension, or you'll feel like even your breathing might change and your heartbeat might change, because it's sending messages to your brain to say you need to react, right? You need to do something about it. And of course, then a possible consequence of that behaviorally is that you are likely to just kind of stay at home and avoid people, avoid work, and that certainly will not give you the quality of life that you would hope for. So be more observant of these functions, and in ways that we can do something about it, we do something about it. So like example, with the glasses, if you don't accept that you have to correct poor vision with glasses, there are other things you can do, like consider surgery, as one of those things. But if you happen to fall into the category that it's not suitable for you, then you have to learn to accept that you have to wear glasses, right? Or like for us, we couldn't put the lashes, then we had to accept that, okay, maybe that's not the correct brand. I'm still not acceptance yet, okay? I'm just thinking, okay, maybe that's not the correct brand. And maybe I need to try a different brand. And then if I try a few brands and it's like, okay, maybe it's just my eyelids, they're oily or something, then I will have to grieve over the fact that I cannot look prettier that way. Right? So watch your thoughts, because sometimes you can change your thoughts. Sometimes you can do something about your physical sensations, like you can, if there's tension, you can stretch, you can do some light exercises, yoga, you can have heat packs, to relieve pain. You can have foot soaks, foot bath, to just kind of help to relieve the pain and stress as well. And be mindful of the behavior. Are you responding in a way that is consistent with the way that you would have otherwise reacted if you were not in pain and you were not upset? Or are you responding more specific to the emotion at that point? So I believe that everyone will probably have similar experiences where your emotions are not permanent. They come and go. Even if you feel very stressed, and you feel stressed a lot, there will still be moments of the day that you feel happy or you feel sad and you feel scared, and that feelings will also come and go. And in the same vein, learning to emotion surf is making space that these feelings will come and go, and we don't have to hold too tightly to it. Okay. Coping strategies, coping statements is something that I would recommend, but I'm not an advocate for positivity. Because for me, I strongly believe that if you're not careful, it can become very toxic. And that's what we call toxic positivity, right? Like example, today was a horrible day. Oh, I know tomorrow will be better. Tomorrow will be a good day. Like I wake up, I know today is going to be a good day. And what if today is a horrible day? Then your positive coping statement is just completely out of the window. Or like, you tell yourself, okay, yesterday I had so much pain. I'm sure today I can't be in that much pain. And what if you are in that much pain? Then your coping statement is out of the window as well. But I like to kind of think of it in a more neutral, non-permanent way to help us cope. There are true statements. So for example, saying something like, this moment is not permanent, and this moment will come and go. These are true statements. It will come and go, it's not permanent, or I can manage this situation. Because the truth is you can, because prior to this moment, you have had many situations that no matter how difficult it was, you managed it one way or another. Or I can, in service of my values, learn ways to manage this situation. So these are more neutral statements that offer some degree of control and some degree of acceptance as well. Okay. Accepting things as they are and not so much how you want them to be is a really important and for me personally also quite difficult thing that I'm working on myself, because oftentimes I want things to be a certain way, right? And if they're not a certain way, then I will have some difficulties adjusting my mindset to that. But that's not the concept of acceptance. Acceptance is, it is what it is, and it's not that I want the pain to go away and I want to live this life that I have in my mind. And while that doesn't mean you cannot have hopes and dreams about that, I think we also need to kind of think about, okay, but what is the current situation? What can I do about the current situation? So if I have a lot of pain in my tummy now, can I put a heat pack so I can accept that it is what it is now? And that leads to the second point of that's within your control, right? So we want to also be more kind of like turn our mind to what's within our control and what's not within our control. So when we, how do I say this? So when we have our mind clearer on, okay, this is something that is within our control and I can do, that often gives us a more sense of like empowerment. And then it also helps us reduce the bandwidth battling the parts where it's not within our control. So an example of what that might be is perhaps having very long periods. I imagine that to be not so much within our control, because that's more it's part of the condition, right? And if we kind of focus a lot of our attention on something that is not within our control, then that means that we are also taking away bandwidth on the things that we can try to control. So I wonder if the things that we can control, that we can have a little bit more effect on, might be pain. So while the pain may not necessarily 100% go away, but things like heat packs, or if necessary, painkillers, or lying down, or having a hot drink, things like that, and they can help to adjust our pain levels. That is us asserting some degree of control on something that we can control. Yeah. Okay. Are we okay so far? Yeah. Okay. Wise mind mode is this concept where we make decisions, where we marry our logical mind and our emotional mind together. So think of it like a Venn diagram, and this is your emotional mind and this is your logical mind, and you put them together, and somewhere in between is your sweet spot. So the emotional mind would be exactly what we might be familiar with when we are dealing with emotions. So, we might be impulsive, we might make decisions that, impulsively, that we're very angry about, or when we are very frustrated about the diagnosis, we might say things to people around us who are helping us, or we might lose it at our doctors, because of the frustration, right? So then that will be a consequence of your emotional mind. Your logical mind is usually very cold and brutal in that sense, right? Like, okay, these are the facts. This is what the doctor has told me, and this is what I can do and what I can't do. And I will not pay attention to how I'm feeling, and I will not pay attention to what I hope and dream. And I'll just suppress all of that, and I will just be robotic about it. So either ends of this spectrum will definitely not offer you a quality of life that sits well with us. But perhaps marrying them both, making decisions that consider your feelings and making decisions that are logical in nature, can help. And an example of how that might look like might include, like, perhaps you feel a lot of pain today, and you are not ready to go out and spend the whole Sunday with your family, and you're so tired from feeling painful and you're frustrated from it. And the emotional mind is just saying, no, I just want to check out and be in bed all night, all day and all night. But that also means that if you continue on that pursuit, then you are likely to be isolated and away from your family members, right? And that's not great for relationships. Then if logically you say, okay, no, this is not helpful. I was told that I should move around, I should try and exercise, I should try and walk, I should, kind of get some movement going, and I'm going to ignore this pain that I'm feeling. I'm just going to go and I'm just going to be out the whole day. Then the consequence of that is likely that you are probably going to end up in more pain. So marrying them both together means that perhaps we can have a midpoint where you can kind of compromise on the activity that you do or the duration of time that you are out with your family, while communicating that you are struggling with pain at the moment. Okay. With empathy and compassion, and this is me referring to ourselves, I think that what makes the pain harder is suffering that we often put on the table and compound the pain. So the concept is that I have in my mind is that pain is something that we cannot run away from, and all the challenges that come with endometriosis is the actual pain of the physical manifestation of it, and the actual pain from your quality of life being affected, and the things that you can do and the activities that you can participate in are affected. There's a lot of pain there, right? But if we don't accept this pain and we reject it, we get angry with it, we beat ourselves up, we are very critical of ourselves, or we kind of lose our tantrum at the people around us, then that suffering that we put on the table, and suddenly this is what you are dealing with instead of the pain itself. So with kindness, empathy, and compassion is something that, while it's often easier to offer to somebody else, I would really encourage for all of us to start to offer ourselves a little bit of that. A little bit more than a little bit, okay? Okay, mindfulness. Mindfulness is how we learn to pay attention in the present moment, because oftentimes I imagine that it can get very overwhelming, particularly when you've had a very difficult day where you were not very productive at work because you were uncomfortable, and then you came home and then you are struggling with your home duties and responsibilities, and at the end of the day you can have this whole big bag of feelings and frustration and anger and all of that, but perhaps mindfulness can help us just pay attention in the present moment, and instead of having to unpack the whole big bag and be very distracted by it and affect what you can do in that moment to help yourself feel better, you are actually compounding your suffering. So mindfulness means like paying attention in a special way, one thing at a time, and just taking on an observer, curious child perspective, where you can start to be curious about your thoughts, about the challenges that you experience in the day, where you can start to be a bit more observing of the physical pain that you are experiencing and the intensity of pain. You can be more observant of the way that you are reacting to the people around you. Yeah. I don't know if it's the anxiety or it's the heat. I have to adjust the temperature. Okay. I value quality of life because I am also a believer that everybody is presented with a different set of challenges in our lives. And I don't think that life is a bed of roses for any one of us. And the challenges can come in different forms and at different periods of our life. And they can be very debilitating. But in some sense, life has to go on. And I advocate for a value-driven direction. So make decisions not purely based on how you feel about it, but start to think about what matters to you as a person. So what are some values that are important to you that you already stand by, or values that you want to develop? Excuse me. So an example of a value that I'm trying to get better at is the value of patience. Because oftentimes my family, I don't think they're really joking, but they kind of give me constructive feedback that my patience run out after like clinic hours. And then when I get home, like they would like me to be slightly more patient. So that's something that I'm trying to work on. And that means that when challenges are thrown at me, or when difficult situations are thrown at me, I want to make decisions, intentional decisions, to behave in a way that is consistent with developing and growing the value of patience. And in the context of endometriosis, I think that is really important, because patience with yourself, if patience is a value that you want to develop and grow, but patience with yourself to sit through the emotion that is coming up very strongly, and that it will go away, or the pain that is coming up and the discomfort that's coming up for you, and that it will go away. So if we make a decision in service of the value, then it gives us a bit more meaning in the decisions that we make. And it's not so much just I'm doing this emotionally in response to how I was feeling at that point of time. Yeah, perhaps a way to help you think about values that are important to you could be, maybe we could take the next few seconds to get you to close your eyes and just imagine that you are at your 60th birthday party. Okay, and Mali, I expect to be there when you are throwing that 60th birthday party. And imagine that all your loved ones, your family and your friends are all there. And somebody walks up and say, in light of celebrating you, they want to give a speech. What do you hope that they will say about you? So not what you think they might say about you, but what do you hope for them to say about you? I think that is a kind of, that suggests to me that those are values that are important to you. And then you can kind of think about, okay, in your current day life, are you making decisions that are consistent with that value? So example would be if you say that, oh, I hope that they will say that, I was dependable and I was kind and I was always there for them. But if you're in your everyday life now, whenever you experience discomfort and pain, then you cancel all your appointments, you cancel your social activities, and you just lock yourself up in the room, then you are not really going to be known to be a social and dependable and available friend by the time you hit 60. So that can be a kind of a way to help you kind of think about values that are important to you. Okay. How do we then manage our thoughts? So earlier we were saying we want to observe our thoughts, right? To kind of figure out what kind of thoughts run through our mind. And some of my patients share these thoughts with me, like, I'm going to die from it. I will no longer be able to enjoy my life. I cannot do anything that I want to do anymore. I am useless. Basically, like, what is the meaning of life and what is the meaning of living now if I have to deal with this? And like, or another one is like, it's my fault. I'm to blame. It's because of my condition that my family has to adjust around me and they cannot do the things that they want because of me. And it's my fault. So these are the common thoughts that my patients have shared with me, but maybe some ways that we can start to think about it, and maybe this is a time that you can start to think about thoughts that come up for you, would be, what is the evidence that supports this? Like, is this reality, or is this thoughts, your thoughts? So your inner world is not the same as the reality of the outer world. So if your inner world can often think that I am bad, or it's my fault, is because of me, but the outer world may not necessarily reflect that. So actually we need to kind of look for the evidence that supports to and against this thought that you have. And sometimes maybe you need to play devil's advocate. And the interesting thing about our mind is when you play devil's advocate, sometimes your mind just kind of turn back and say, no, it's not actually not this bad. So you can try and see how that works for you. And then maybe you can also ask yourself, what is the best and worst thing that can happen if you make this decision or another decision? So one thing I like to ask my patients is, really, what is the worst thing that can happen if you make this decision? Because in today's world, even trees can move. Last time, for a very long time, there was a saying that you are not a tree, so you can move, right? Trees don't move. But now in our world, even trees can move. You can uproot them and you can relocate them. So that means that any decisions that we make, we can always make another decision, and it's not necessarily always set in stone. So what is the worst thing that can happen if you make a decision like that? Okay. And with compassion and with empathy, what would you tell a friend or a loved one who is going through this situation? What would you say to them? How would you support them? Will you tell them that, yes, you are useless? Yes, your life has no meaning anymore and you cannot do anything you want to do. And yeah, it's your fault. Or you might maybe say something like, hey, there are some things that you can't do at the moment, but maybe you can do it next time. Let's think about what are the other things that we can do now. So, if you can accord your friends that kindness and that empathy, perhaps we also owe it to ourselves to have a little bit of that. All right. Ask for support is often a concept that I think it's slightly challenging, particularly in our culture. And if we don't ask it carefully, in that sense, we may end up suffering consequences for it, right? So asking for support, first we need to change the way we are thinking about asking for support, because wanting to be independent and being independent doesn't mean you cannot ask for help. You can be independent and still ask for help. And you can be independent and you can still need help. Okay. And you are not a burden. Burden is a very unnecessary, useless label, if you ask me. Because what does that tell you about it? And what can you action from it? It only is designed to make you feel worse. And then what happens? But maybe if we can change the words that we are using to think about the way that we are thinking about endo, that is likely to have an impact on how we will feel and react to it. So if I tell myself I'm a burden, I'm going to really feel like crap, right? But if I tell myself, no, actually, I'm not a burden, I have a condition called endometriosis, just like someone I know has a condition called cancer, and someone I know has diabetes, and someone I know has anxiety disorder. And we all have different challenges in our life at different points of our life, and this is mine to deal with. And I wonder if there's a kind of like a difference, when you say I'm a burden versus just recognizing that, this is you as a person and this is something else that you have, and it doesn't reflect who you are as a person. Yeah, perhaps we can also prepare ourselves for the request, particularly when it's difficult to ask for help. Maybe you want to start to kind of like rehearse in your mind how you might do it and how you could phrase the request. And also timing is important, right? Like, kind of example, if your partner is very frustrated and very stressed and in the middle of a meeting, then maybe I may not want to pick that time to go and ask for support. I might either see if I can wait it out or ask another family member. So like timing is also important. And we want to try to be as clear and as specific as we can. Yeah. Okay. So ask for support, right? So educate your loved ones on some telltale signs. So example, perhaps you can say, if you see me curling up in bed, can you make me a hot drink, please? So you can plan ahead. You are already familiar with the situations that you are likely to be caught in. And if you already have these ideas, perhaps you can also kind of think of problem solve and think of strategies to help them help you, right? And also be kind to yourself. There'll be times that you might feel overwhelmed, and allow yourself to have that window where you feel a bit overwhelmed and a bit of that downtime, and definitely express some gratitude and appreciation when help is offered to you. Sorry, I'm just aware that I've overrun. I don't have very much left. Can I keep going? Yeah? Okay.
Yes.
Okay. How can the family support us? And perhaps this is something that we can communicate with our family members. I've kind of divided it according to emotional help and practical help. So as a family member, maybe we can be more expressive with the compassion and the empathy. And that's not just really in a form of what you do, but how you say. So, you can learn to be more, like you can try to be more flexible, like, don't worry, if we can't do it now, we can do it later. And we can actually say it instead of just just kind of show it in action. Or we can just kind of tell them that, it's really okay. I can see that you're in pain now, go and get some rest, let me know if there's anything that I can do to make you feel better. Leave the dishes, I can clear them today, right? I think the very precious thing is about listening, and listening is very different from hearing. So listening is really listening to what the person is saying and not saying, and taking an active interest. versus hearing is really more like, I just want to tell you what I want to tell you, and I'm not really listening to what you're saying. So listening sometimes just means making some space and just allowing that person to vent and to cry and to tell you how frustrating this process is without necessarily problem solving for them, but just validating the emotion that they're experiencing. Yeah, and you can acknowledge their feelings and validate their strengths. Very oftentimes, I think there's a lot of focus on what's not going well for us and our weaknesses and our challenges and our struggles. But if we can also turn our mind to a bit about the strengths and the resilience and the values that our family members are exhibiting, perhaps we can also encourage them by highlighting these strengths and values. Okay. Practical support, and I'm sure a lot of family members might participate in this by, just kind of helping and learning a little bit more about the condition, keeping track of the appointments. And if you cannot make it down for the appointments together because of, commitments, be even just checking in after the appointment, how did it go? What did the doctor say? How can we help? Or, what's the next follow-up, or when's the next follow-up? Can be really a way that is really important to the sufferer, because you get that emotional support and love even though your family members may not be physically there. And definitely, continue to encourage them to pursue their interests and hobbies. So try not to give it up completely. So, you may not be able to participate in a very, a very active sport or an extreme sport for a longer period of time. But maybe if we can scale it down to something that you still enjoy, or adjust the time, you can still have enjoyment of things that you like to do. But maybe the intensity and frequency is something that we can try to adjust otherwise. And of course, caregivers must look after yourselves, because if you are not happy and you are burnt out and you are stressed, then you will also not be in a position to support your family members, and that's likely to end up in more conflict. Yeah. Okay, very quickly, what not to say or do. Definitely no blame or criticize, like, oh, you agreed to do this with me and then you pull out, and then, you always back out. Why can't you do it? You're being lazy. And I think the common one that comes up with my patients is, you are lying, right? You are just using your diagnosis to get out of your duties, to get out of your responsibilities. And I often tell my patients, trust me and I trust you that you would rather do these chores than to actually have this diagnosis to deal with and to use this as an excuse. So don't minimize the pain. Like, you should be glad this is not cancer. You should be glad this is not something bigger. I don't think that they are comparable, and they are all different challenges, different diagnoses, different struggles, and they have difficulties of their own. Or like, oh, when I have menstrual cramp, I eat Panadol and then I'm okay, and then I can get on with work. What? Why can't you? Are you pretending? Or, you should feel okay. I put on a heat pack, it works for me, so it should work for you. Everyone is different, right? And the intensity of pain is different. Okay, that's all I have. Sorry about the overrun. Any questions I can take, if there's still time for questions?
Thank you, Dr. Annabelle. This is such an informative segment. It is laden with useful tips, which I look forward to implementing myself. We have exceeded our event, so I don't think we are able to accept questions at the moment. But I do wish that, probably in the future you can plan one session just with yourself, perhaps, so that maybe we can take more questions in the future from the floor, if that's okay. That will be later on. I will speak to you personally. Okay.
Yes. We can do that.
All right. Awesome. Okay. Not to worry as well. If ever you need to refresh this session today, this event today, it is streamed live on YouTube. You just have to search for Namira Muhammad from the YouTube search engine. In fact, all the information, the contact details, everything, I will be putting it up in all my social media accounts. That will be in my Facebook, website, EndoSupport SG, Instagram, E for endometriosis. And if you have yet to follow, subscribe, like, and share, please do so. That's quickly saying like an influencer. All right. So it looks like that's it for today. Just a quick shout out to everyone here. Thank you for joining us. And also, don't forget, if Endometriosis is representing Singapore in the Worldwide EndoMarch, which is based in California. So this EndoMarch, Worldwide EndoMarch, is the organization that set up the EndoMarch Global Movement, which was the first global campaign involving a worldwide synchronized event for the cause of endometriosis. And the event is happening right now as we speak. So show Team Singapore E for endometriosis some love. And the information, you can find it in the Instagram or our website, EndoSupport SG. And the next event will be on the 17th of April, Sunday from 2 p.m. to 4 p.m., also listed on the website. Yeah, I think that's about it. With this said, please take some time to provide your feedback by completing the short survey questionnaire as you leave the Zoom. And to the panelists, thank you once again for being generous with your time and supporting the cause. And I love the wafting positive energy you guys are showing here. I'm reading all the chat box, all the comments, amazing comments, feeling the love, and back to each and every one of you, all the love and kindness. Until the next event, please take care and stay safe. Have a wonderful rest of the day. Goodbye.
Thank you, everybody.
Bye-bye.
Bye.